Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation, which will be held by two great moderators and speakers, Professor Dawla Bilal and Professor Ghada ElKanishi. Our moderator today is Professor Dawla Bilal, Professor of Nephrology and Internal Medicine, Cairo University. And she is the head of the committee of the Ministry of Health Board, Egyptian board. She is the past president of the Asr Al-Aini Nephrology Dialysis and Transplantation Center. Welcome, Professor Dawlat, and our speaker is Professor Ghada ElKanishi, which will be introduced by Professor Dawla Bilal today, and she will speak about endocrine hypertension. Please, Professor Dawlat, start.
Thank you, Yasser. Bismillah ar-Rahman ar-Rahim. I'll present Professor Ghada first in English for non-Arabic speaking attendees, and then I will present her in Arabic. Professor Ghada ElKanishi, she's a professor of internal medicine and nephrology in University of Mansoura. She is the head of the nephrology unit in Mansoura University Hospital. When she was in internal medicine, department, she was majoring endocrinology. And that's why today the lecture is going to be endocrinal hypertension. Apart from the above logistics, Professor Ghada is a very knowledgeable person. She was the first in her class during her medical school. She's an outstanding character, being humble and friendly and ethical and very polite and extremely respectful to all her colleagues. Today, as she was very into endocrinology before joining nephrology, her talk will be endocrinal hypertension, a subject which needs mastering of both endocrinology and nephrology. بسم الله الرحمن الرحيم. هقدم الدكتورة غادة بالعربي دلوقتي. أستاذة دكتورة غادة القنيشي، أستاذ أمراض البطنة والكلى بجامعة المنصورة، رئيس وحدة أمراض الكلى بمستشفى جامعة المنصورة. هي في الأول كانت بطنة and then she joined اسم الكلى، وكانت endocrinology أساسا. كانت متفوقة جدا والأولى على دفعتها، وتتسم إنها بالأدب الجم وشخصية خلوقة جدا ولطيفة ومحبوبة ومتواضعة. إن شاء الله تقدم لنا النهاردة very fruitful and very rich lecture. تفضلي يا دكتورة غادة.
شكرا جزيلا, and thank you, Dr. Dawlat, Professor Dawlat, for this kind and this generous presentation for me that I don't deserve. In fact, it is
ده بالإجماع يا غادة، والله بالإجماع.
ربنا يخلي حضرتك يا دكتورة دولت، من ذوقك دايما. It is my pleasure to be with my professors, Dr. May Hassaballah, Dr. Saeed Khamis, Professor Dawlat as a modulator of this meeting, Professor Yasser, and I hope that this meeting will be fruitful for all of us. The title I was asked to present today is about endocrine hypertension. So first, what is the prevalence of secondary hypertension? Endocrine hypertension being a part of this secondary hypertension. Approximately 1/3 of hypertensive population had secondary hypertension. 50% of children presenting with hypertension will have secondary hypertension, and about 1/3 of young adults less than 40 years were reported also to have secondary hypertension. So what is the indication to evaluate a patient for secondary hypertension? According to the 7th report of the Joint National Committee on Prevention and Detection, Evaluation and the Treatment of High Blood Pressure, GNC7, a patient with acute rise in blood pressure in a patient with previous stable reading, age of onset before puberty, age younger than 30 years in non-obese, non-black patient with no family history of hypertension, malignant or accelerated hypertension with signs of end organ failure or damage.
Sorry for interruption, Dr. Ghada. Please enlarge the screen.
هي مش enlarged، أنا كنت عاملاها
Make it full screen to be clear.
تمام كده.
That's it. Thank you. Thank you.
Sorry. To continue the indication of screening for a patient with secondary hypertension, severe hypertension with a systolic blood pressure above 180 and diastolic blood pressure above 120, or resistant hypertension with its definition as a persistent elevation of the blood pressure despite 3 adequate antihypertensive medication, including 1 diuretic. So secondary hypertension may be due to primary renal disease, the commonest cause of secondary hypertension, drug-induced oral contraceptive, corticosteroids, sleep apnea syndrome, congenital or acquired cardiovascular disease as coarctation of the aorta, and endocrinal causes. The prevalence of endocrinal causes is less than 15% of all hypertensive patients. We have many causes of endocrinal hypertension, chromocytoma, primary hyperaldosteronism, Cushing syndrome, hyperthyroidism, hyperpara, acromegaly, Cushing, thyroid-dependent causes, and many other causes are related to endocrine hypertension. In fact, endocrine hypertension is a matter of concern that many books are published in this era or in this area of medicine. So just to be to the point and to get the best benefit of this meeting, causes of endocrine hypertension can be classified into adrenal causes, whether cortical related causes or medullary causes as chromocytoma, or non-adrenal causes of hypertension related to the growth hormone excess, primary hyperpara, testosterone deficiency, or obesity related, or even diabetes as one of the metabolic and endocrinal diseases. The most common endocrinal hypertension is caused by primary or excess production of mineralocorticoid, primary hyperaldosteronism, others including chromocytoma, Cushing, and thyroid-related disorders. So I will briefly and during the next slides summarize the effect of mineralocorticoid as a cause of hypertension. My agenda will include the regulation of mineralocorticoid secretion and action, causes of mineralocorticoid-induced hypertension, primary aldosteronism, etiology, diagnosis and management, and rare other syndromes related to this hormone. So as we know, we have the adrenal cortex with its 3 layers, zona glomerulosa, fasciculata, and reticularis. Aldosterone is secreted from the zona glomerulosa. However, there is an interaction in the senses between all the 3 hormones produced, main hormones, sex hormones, cortisol and aldosterone, produced by the adrenal cortex. So physiologically, aldosterone is the last step in the activation of the RAS system. Hypovolemia or decreased renal perfusion will stimulate renin for the transformation of angiotensinogen into angiotensin. Is in the lung will transform angiotensin 1 into angiotensin 2. Finally, this will affect or stimulate the adrenal cortex to produce aldosterone. And the feedback after aldosterone exerts its effect is to suppress the renin secretion. Mineralocorticoid or aldosterone acts mainly on the mineralocorticoid receptors in the principal cells of the distal nephron. The net effect of this classical aldosterone action is reabsorption of sodium and then water full of sodium, and increased urinary excretion of potassium and hydrogen. Aldosterone, on the other hand, have many non-classical extrarenal effects through its receptors in the cardiovascular system. It will induce modulation of the vascular tone, stimulation of inflammation, fibrosis, and may lead to end organ, especially in the cardiovascular tissue, damage and fibrosis. What are the causes of mineralocorticoid-related hypertension? These can be classified into causes with high renin. This means secondary hyperaldosteronism. The commonest cause, renal artery stenosis, coarctation of the aorta, or renin-producing tumor, which is very rare, or low renin-dependent excess mineralocorticoid secretion, as in primary hyperaldosteronism, or there may be low renin, low aldosterone associated with hypertension in certain diseases. So what is primary aldosteronism? Primary aldosteronism, or Conn's syndrome, was first discovered by Conn in 1954. He reported the clinical syndrome of hypertension, hypokalemia, metabolic alkalosis, due to excessive production of aldosterone, and the syndrome continued to bear his name till that moment. What is the prevalence of primary aldosteronism? In this study, including more than 1,000 hypertensive patients, endocrinal hypertension present about 18% of the population or the study population, and primary aldosteronism was observed in about 14 or up to 15% of the cases. Moreover, there is unrecognized prevalence of primary aldosteronism. This cross-sectional study studied the objective or the aim of this study is to characterize the prevalence of renin-independent aldosterone production and its relation to hypertension or to blood pressure. Participants in this study were normotensive, stage 1, stage 2, and patient also with resistant hypertension. And the prevalence of hypertension in these patients ranged from 11% in normotensive patients and increased up to 22% in resistant hypertension. What is the incidence of hypertension and aldosterone increase in non-hypertensive person? This is very interesting studying the incidence of hypertension in non-hypertensive participants, about 1,700 non-hypertensive participants, which were sharing in the Framingham offspring study, and they were followed for 4 years, and they discovered and concluded that the increased plasma aldosterone concentration, even within the physiological range, predispose the person to develop hypertension. The etiology of primary aldosteronism may be familiar, runs in family, or may be sporadic. The most common cause presenting about 60% is adenoma, aldosterone-producing adenoma. Bilateral adrenal hyperplasia represent about 30%. We have other rare causes like unilateral adrenal hyperplasia, familial hyperaldosteronism, or carcinoma. For familial primary aldosteronism, we have 4 types. These are 4 distinct types with different genetic variants. And as well, there are different clinical manifestations, as well as hypertension severity, CT manifestation, which may be normal in the type 1 and with evident macronodular hyperplasia in type 3, and as well as in treatment. Fortunately, it is a very rare type of primary aldosteronism. However, nowadays we have a new syndrome, which is the syndrome of subclinical primary aldosteronism. This is related to aldosterone producing cell clusters. The discovery or the histopathological discovery of these cell clusters sparked another leap in the understanding of primary aldosteronism pathogenesis. This recent hypothesis yielded in 2018 suggests that the newly described foci, which is known as aldosterone-producing cluster, may present a precursor of adenoma or adrenal hyperplasia. These are non-suppressible aldosterone synthesis cells. These cells are related to age. In this interesting publication in 2017, they studied the relation of age to autonomous aldosteronism or to the aldosterone-producing cell clusters in about 127 normal adrenal gland derived from diseased kidney donors. The age ranged from 9 months to 68 years. The histopathological finding parallels or documented an age-related autonomous aldosteronism and abnormal aldosterone physiology that predispose or may be an explanation for the age-related cardiovascular risk. The pathophysiologic action of aldosterone is not just related to the kidney and its effect on the electrolyte, but it is through the mineralocorticoid receptors present in the cardiovascular and the cardiovascular system has become a risk factor for many cardiovascular pathology. This pathophysiological action of or pathological action of aldosterone were studied in 2018 and patients with primary aldosteronism, when compared with matched patient with essential hypertension, have increased left ventricular wall and carotid intimal medial thickness, impaired diastolic and endothelial function, higher incidence of atrial fibrillation, coronary artery disease, and heart failure. The author concluded that primary aldosteronism is considered to increase the cardiovascular risk and death independent of blood pressure effect alone. Even in treated patients with mineralocorticoid receptor antagonist, patients with primary aldosteronism have a twofold higher risk for developing MI, heart failure, and hospitalization, stroke, and even mortality than patients with essential hypertension. In this study, the prevalence of PA or primary aldosteronism in patients with hypertension were found to be about 6%, and notably these patients were more frequently with target organ damage and cardiovascular event when compared with other patients with essential hypertension, which was confirmed by the previous study. What about the kidney? Renal damage in primary aldosteronism. This study is related to the PAPI study, which is the study studying the prevalence of primary aldosteronism in Italy. They concluded that among the hypertensive patients with preserved GFR, those with primary aldosteronism have a urinary albumin excretion rate higher. In fact, they were higher in the results than that of pulmonary with primary or essential hypertension. So the hypertension, because of excess autonomous aldosterone feature, may produce early renal damage. This was documented by many other studies. The last one in 2019 and they concluded that primary aldosteronism prior to targeted therapy are also at higher risk of kidney disease, including increasing in the GFR, increased albumin excretion, and even death in this patient, as well as chronic kidney disease and accelerated progression of chronic kidney disease. What are the clinical features of primary aldosteronism? First of all is hypertension. Second, hypokalemia, although it is not a fixed feature. It is present in about 1/2 only of the cases. This patient have a characteristic lack of edema, metabolic alkalosis, maybe sometimes mild hypernatremia, increasing proteinuria, and and increasing in the GFR, muscle cramps, and maybe later muscle weakness related to hypokalemia, and cardiovascular complication, myocardial infarction, atrial fibrillation, and so on. Hypertension is not present in all cases, and as we mentioned before, a normotensive patient may have high aldosterone, and this is a risk for consequent development of hypertension. Hypokalemia, in 50% or even more of cases, there is normal potassium level. The lack of edema is caused by the release of atrionatriuretic peptide after aldosterone produce sodium and water retention. So this is known as the escape phenomena, where atrionatriuretic peptide will result in absence of edema and decrease in the volume expansion. Interestingly, this disease, primary aldosteronism, have an association with obstructive sleep apnea. Results of this study showed that about 9% of patients with obstructive sleep apnea have hyperaldosteronism. This was a cross-sectional multi-ethnic study. This study concluded that the challenge of the current recommendation of the Endocrine Society for screening all patients with obstructive sleep apnea for the presence of primary aldosteronism. What about the diagnosis of primary aldosteronism? When to suspect, the Endocrine Society clinical practice guideline for diagnosis and treatment of a patient with primary aldosteronism, which was released in 2016, highlights the patient or the high-risk population to be screened for primary aldosteronism. Those patients with sustained blood pressure elevation more than 150/100 on 3 or more measures on different days, patient with hypertension resistant to 3 or more antihypertensive medication, or patient requiring 4 or more antihypertensive medication to attain their blood pressure control, patient with sleep apnea, patient with either spontaneous or diuretic-induced hypokalemia, patient with hypertension and incidental discovered adrenal mass or adrenal adenoma, patient with hypertension and family history of early onset hypertension, cerebrovascular accident in age less than 40 years, or hypertensive patient with who are first-degree relative of patient with primary aldosteronism. What about the diagnosis? The diagnosis of primary aldosteronism means first identifying those who have autonomous aldosterone release, and secondly, identifying the source of this hyperaldosteronism. We have 2 types of renin assay. First one, measuring the renin activity as the rate of conversion of angiotensinogen to angiotensin 1. And the second is the direct measurement by immune assay of immunoreactive renin. In fact, the second type of renin assay have got more popularity nowadays. However, the renin activity is more sensitive at lower value than direct plasma assay and it is the more often used in clinical practice. The diagnosis, whenever we have an elevated aldosterone and low renin, this is highly suggestive of primary aldosteronism. However, this ratio of elevation of aldosterone and renin ratio may occur when there is a suppressed renin and low aldosterone. So diagnosis of primary aldosteronism needs the combination of an elevated aldosterone-renin ratio and the documentation of the presence of a non-suppressed aldosterone level. This will decrease the false positive results. So diagnosis of primary aldosteronism means elevated aldosterone-renin ratio and non-suppressed aldosterone level. The cutoff, there is great difference in the cutoff, but the most widely used cutoff for aldosterone concentration is at least 15. Some use less frequent cutoff point of 10, and with aldosterone-renin ratio at least 30 nanogram. What are the precautions to be taken for more correct aldosterone-renin ratio as a screening test for primary aldosteronism? First, hypokalemia will lower aldosterone secretion. So to avoid this effect, we should correct hypokalemia before performing any test. Plasma aldosterone concentration, low salt or diuretic use will result through depletion of potassium or depletion of volume, will result in high aldosterone secretion. So measurement of 24-hour urinary sodium excretion to estimate salt intake and ensure adequate salt intake before doing the test. Withdraw any diuretic agent at least 4 weeks before testing. For renin, know what you are using. If you are using the direct assay, so you will have a cutoff point different from that of active renin assay. So this should be known during the assay, which type is used for renin assay, renin activity or direct renin assay. Patient positioning, keep the patient supine or sitting for 60 minutes before sampling. Although this is a long time, the plasma half-life of renin and aldosterone roughly around 15 minutes. So it is sufficient to keep the patient in the supine or sitting position, one position, not moving for about 15 to half an hour. Handling of the sample, this is completely different when giving for the direct renin assay, there is no precautions, while for the plasma renin activity, the sample should be added in iced water to avoid the conversion of angiotensin 1 and the generation and consumption of angiotensin. Drugs, alpha blockers, doxazosine and long-acting calcium channel are allowed. Mineralocorticoid receptor antagonist can be allowed, but it is better to avoid using these drugs. And we will discuss the effect of antihypertensive on the test in the next slide. Okay, then using special apps for calculating the aldosterone-renin ratio. We have other precautions. The patient should be awake for about and ambulatory for more than 2 hours. So the mid-morning sample is the most accurate. And as we mentioned, the patient should be seated for at least 15 minutes prior to blood drawing. Drugs that alter aldosterone or renin can have a false positive or false negative, can result in false positive or false negative results. Beta blockers, central alpha agonist, lower the ratio, lower aldosterone, and can result in false positive ARR. Diuretics, ACE inhibitors, ARBs can increase aldosterone and can result in negative screening result. However, if the ARR is high on this medication, if it is done and this medication can't be stopped and it is high with frank elevation of the plasma aldosterone and suppressed plasma renin activity, there is a high likelihood of primary aldosteronism. MRA or mineralocorticoid receptor antagonist, spironolactone and eplerenone can cause false positive or false negative ratio and raise the plasma renin activity. However, if plasma renin activity is suppressed on this medication, the test is still interpretable. However, if it is not suppressed and unsuppressed ratio in or unsuppressed plasma aldosterone in patient on a mineralocorticoid receptor antagonist, these drugs should be discontinued before repeating the test. Sure that understanding the impact of various medication, especially in this patient who are usually hypertensive, is very important for ideal test. So the antihypertensive, it's better to be that interpret with the results should be withdrawn 2 to 4 weeks prior to screening. MRA, because of their longer duration, should be stopped. Can you hear me?
Oh, yes.
Yes, because I have a notification.
Yes, you can.
Sorry.
Yeah, no problem.
So, should be stopped at least 4 to 6 weeks prior to testing. We have medication with neutral effect on the renin and aldosterone, like calcium channel alpha blockers, which can be used during the screening or the washout period before the test. So it is a very tough subject and tough maneuver to do the aldosterone, plasma renin, and do all these precautions. So the question is there any other biomarkers that may have a higher sensitivity for screening of primary aldosteronism? Yes, we have some publication, although of limited use. This first one published in Hypertension in 2013, they documented that the titer of angiotensin II type 1 receptor autoantibodies were elevated, and they can discriminate patient with adenoma or adrenal hyperplasia from those patients with essential hypertension. Additionally, there is a crosstalk between the adrenal hormones and the parathyroid hormone, and raised serum parathyroid hormone level may be a feature of aldosterone-producing adenoma. Also, these biomarkers are not yet for use, or not the evidence is not yet sufficient to use these biomarkers in addition or to substitute the ARR. So what is the diagnostic strategy for evaluating a patient with PA? First, we should do the ARR. If it is suppressed, this primary aldosteronism is unlikely. If the aldosterone level is more than 15, or in some use the cutoff of 10, and a high ratio above 30 or above 50, then we can start MRA receptor blocker. And in the patient in the midway between these two figures, we should do some confirmatory test. We have many confirmatory tests, starting with just increase the sodium intake for 3 to 4 days using sodium chloride tablets or whatever the source of this sodium, and measure the plasma aldosterone level to confirm the diagnosis, or use intravenous saline infusion. Recently, captopril can be used as a challenging and confirmatory test, and also cortisone fluorocorticoid suppression test may be used as well. None of these confirmatory tests have a 100% sensitivity or specificity. Tests that require salt loading may be problematic because of the raise of the blood pressure in patients with hypertension or poorly controlled blood pressure. These tests needs the same precautions as during measuring aldosterone and renin, stopping the antihypertensive, and so on. A study using including about 150 hypertensive patients found that using renin-angiotensin blockade with captopril or dexamethasone may be less costly and more rapid and safe, and have a sensitivity of about 98% and specificity of 100%. So now we diagnose primary aldosteronism. Secondly, we should identify the cause. Sometimes we just rely on the previous data in addition to some other characteristics, like age of the patient less than 50 years, patient with severe hypokalemia less than 3, high plasma aldosterone level more than 25, high urinary excretion of aldosterone. This may favor the diagnosis of adenoma versus bilateral adrenal hyperplasia. However, these clinical tools lack validation and depend on experience and not on a large cohort or a study results. So to identify the cause, we must do localization. Localization is best done with CT, spiral CT. Spiral CT will exclude the presence of large masses more than 4 centimeters. The other way of localization, which is considered the gold standard for localization, is the adrenal vein sampling. Adrenal vein sampling involves sampling from the right and left adrenal vein, as well as the inferior vena cava, to measure aldosterone and cortisol concentration. Many favor performing this maneuver, especially in unexperienced centers, after the administration of ACTH. This administration of this ACTH, synactin, will prevent the stress-induced fluctuation in aldosterone secretion during the procedure. The interpretation of adrenal venous sampling depends on many indices, the selectivity index, the lateralization, and the contralateral ratio, but at last, this maneuver can diagnose which adrenal gland, or if both of the condition is unilateral or bilateral, secretion of autonomous secretion of aldosterone. So this is a very complicated maneuver, adrenal vein sampling. And we have argument against using a venous sample. This adrenal vein sampling also considered the gold standard for localization and recommended by experts and the expert societies as well. Adrenal venous sampling had never been tested in randomized controlled trial since 2016. Several studies have debated the need of this maneuver at adrenal vein sampling, and there is still no consensus about that issue. This interesting trial compares the adrenal vein sampling versus CT scanning in primary aldosteronism. So during the study, patients were randomized whether they had CT-based determination of the presence of primary aldosteronism or aldosterone or AV, adrenal vein sampling decision-making. And the primary outcome of this study was the intensity of antihypertensive medication as measured by a definite daily dose. And they discovered the outcome of this research or this large trial found that there are similar. The median drug dose in patient diagnosed by CT is the same as that patient diagnosed by adrenal venous sampling. Treatment of primary aldosteronism is surgical in presence of adenoma, which is the commonest cause of this cone syndrome. And it's often performed with laparoscopy, whether anterior or posterior approach. A newer treatment approach is by the use of radiofrequency ablation. Radiofrequency have been demonstrated to be safe and effective, and the long-term outcome, no difference to surgical resection, but it is clear that the only disadvantage of radiofrequency that its inability to obtain histopathology. Medical treatment is the treatment of choice of benign bilateral adrenal hyperplasia, and in patient refusing surgery, the treatment is by mineralocorticoid receptor antagonist. Spironolactone doses required between 550 and 400 milligrams per day, once a day. The dose is titrated every 2 weeks until the serum potassium level is 4.5. Hyperinone has a shorter half-life, more effective in twice daily dose, starting dose to 25 milligram twice daily, and it may need up to 100 milligram per day. The treatment target is mid to high normal serum potassium concentration without the aid of potassium supplement. This is sufficiently to document mineralocorticoid receptor blockade. And in addition, we can monitor the plasma renin activity with optimal activity more than 1 nanogram. So these are the goals. Phenylenone, which is a non-steroidal mineralocorticoid receptor antagonist, have a great benefit in retardation of CKD due to its antifibrotic and anti-inflammatory effect. This neural MRA antagonist have shown a beneficial and anti-fibrotic effect on cardiac and vascular with minimal side effect as regard in kidney. However, its evaluation is not yet for use in these cases. Another issue is the use of high doses versus low doses of mineralocorticoid receptor antagonist. Does it differ? Yes. So in several studies reported that patients treated with high doses of MR antagonist whose renin activity was increased has significantly risk for major cardiovascular event compared with patients treated with lower dose in whom renin activity was not unsuppressed or remain suppressed or undetected. If blood pressure is not controlled, we can add other antihypertensive treatment, or if we have a complication due to MRA use, potassium sparing diuretics can be used, calcium channel blockers can be used effectively in these patients. A newer drug which is directed or selectively inhibit the synthesis of aldosterone through inhibition of aldosterone synthase. This is in the preclinical or early clinical. It is just used in mice and monkeys, but it has a high potency and we are waiting for such drug. So after CT imaging, and if we have a positive results, we will pass to adrenal vein sampling. If the CT is negative, we will put the patient on a mineralocorticoid receptor blocker if adequate blood pressure is reached. So we will optimize the use of this mineralocorticoid blockers. If not, the patient will pass to adrenal vein aldosterone sampling. And according to the result of sampling, if we have a unilateral aldosterone release, this means that we have an adenoma. Adrenalectomy, unilateral adrenalectomy is the line of treatment. This is all for primary aldosteronism, but we have other causes of mineralocorticoid-induced hypertension. Besides the primary and the secondary aldosteronism, we have certain conditions in which we have low renin and low aldosterone, but they resemble primary aldosteronism and they are known as pseudo-primary aldosteronism. And in the next slides, I will discuss some of these syndromes. Liddle syndrome and apparent mineralocorticoid excess syndrome. Liddle syndrome and apparent mineralocorticoid excess syndrome are two genetic hypertension, have the same clinical manifestation of mineralocorticoid excess as regard the early onset hypertension, hypokalemia, and metabolic alkalosis. But in these cases, we have low renin and low aldosterone level. In Liddle syndrome, it is an autosomal dominant, in which the defect is in the same receptor, the sodium channel receptor in the collecting tubules and the distal convoluted tubules, resulting in hyperfunction and secondary clinical manifestation of mineralocorticoid excess. The treatment of Liddle syndrome is through the use of potassium-sparing diuretics. The other syndrome, which is the apparent mineralocorticoid excess syndrome, it has another name, Ulick syndrome. It is an autosomal recessive due to decrease in a certain enzyme which convert cortisol to inactive cortisone in the renal tubules. The difference between cortisone and cortisol is that cortisone does not bind to the mineralocorticoid receptors, while cortisone and aldosterone bind with equal affinity to the receptors. Normally, the circulating concentration of cortisol are 100 or even 1,000-fold higher than those of aldosterone. So more cortisol will be available to bind to this receptor, and there will be an increased cortisol-mediated activation of the receptor and secondary clinical manifestation of mineralocorticoid. And this is the same mechanism which occurs with over-ingestion of liquids. Congenital adrenal hyperplasia, the commonest or the classical type with 21-hydroxylase deficiency, but we are talking about hypertension and the rarer form of congenital adrenal hyperplasia affecting the 11-hydroxylase or the 17-hydroxylase enzyme can result in hypertension with hypermineralocorticolism. Due to a decrease of the deoxycorticosterone and resultant excessive mineralocorticoid receptor activation. So this is all for my lecture today. I will summarize the lecture that endocrine hypertension account for up to 15% of the secondary form of hypertension. There is a variable prevalence encountered in the literature from 2% up to 15%. Aldosterone regulation plays a crucial role in maintaining intravascular and effective circulating volume and potassium homeostasis. Primary aldosteronism is relatively common, yet often undiagnosed cause of hypertension. Inappropriate regulation of aldosterone with hypertension is associated with increased morbidity and mortality independent on its effect on the blood pressure. Studies reported prevalence of primary even in normotensive patients. The syndrome of primary aldosteronism is characterized by hypertension with excessive autonomous aldosterone production and is usually caused by either adenoma, about 60% of the cases are due to adenoma, or bilateral adrenal hyperplasia. The diagnostic workup of primary aldosteronism is actually very hard and contains 3 phases of screening, confirmation, and differentiation of unilateral from bilateral form. Primary aldosteronism is screened by measuring plasma aldosterone and renin activity, either using the direct renin activity or the direct renin concentration. Treatment is either surgical by laparoscopic adrenalectomy in cases of unilateral adenoma, or medically by mineralocorticoid receptor antagonist. And finally, thank you.
Thank you very much, Professor Ghada. أنا مسموعة كده يا دكتور.
Yes, you are clear.
Thank you very much, Professor Ghada. This is very rich. يعني what you mentioned is very rich. خصوصا that you summarized it at the end and stating that the renin estimation is very difficult. Is it really practically done? يعني to stop the antihypertensive treatment and replacement by other drugs and keep the patient sitting for 60 minutes, and is it practically useful? Well, we measured aldosterone antibodies or aldosterone assays straight away.
Yeah, Dr. Dawlat, thank you for your question. Actually, it is the balance between to treat or to diagnose. So, yes. Yeah, you can just add a mineralocorticoid receptor blocker, antagonist, and we can assess the result. If the CT does not show an evident pathology, an adenoma, that's what I mean. So it is actually just to diagnose or to treat. And even in algorithm and in literature, they many of them do not depend even not in Egypt, even in UK or in the USA, sometimes they just add the mineralocorticoid receptor blocker, and they see they follow the patient.
Yes.
At the end,
Are there points to make you doubt that this is primary aldosteronism, primary hyperaldosteronism?
Yeah,
go straight away to try treatment,
Yes, but
the hypokalemia, is it the hypokalemia mainly?
Have many points of concern to consider the patient at high risk to diagnose primary aldosteronism. As I mentioned in the Endocrinal Society guidelines, including patient with family history of primary aldosteronism, patient with hypokalemia, even whether spontaneous induced or diuretic induced, patient with hypertension, resistant hypertension or refractory hypertension, and patient young age, patient with hypertension. But usually we suspect primary aldosteronism if we have hypertension with hypokalemia. Yeah. Usually this is the first step or the first clue for diagnosis for proceeding or for preceding in the diagnosis of primary aldosteronism. But unfortunately, hyperkalemia is present in 50% of the cases, and the other half will not have abnormalities in their potassium level.
Right. Thank you.
Excuse me, Professor Dawlat, even measurement of serum aldosterone is difficult.
The same precautions.
But even with using, due to all of these precautions, it's very difficult to depend even on serum aldosterone for diagnosis. So I think that the only tool we have in our hands is the hypertension with the hypokalemia, and depending on the high prevalence, and to keep in mind the high prevalence of primary hyperaldosteronism in this case. So as biochemical measurements is very difficult, both renin and aldosterone assessment.
Right, and especially in bilateral cases, you just have to depend on the treatment, on the medical treatment.
Yes.
Right? Bilateral adrenal hyperplasia, there's no place for surgery here. Right?
Dr. Ghada?
No, I'm sorry. Bilateral adrenal hyperplasia is medically treated. And even
medically, only medically.
Yeah, it's medically. And in some cases, when adenoma have the higher suspicion and not carcinoma is rare. Sometimes the surgery is not. Can you hear me, Dr. Dawlat?
Yes.
Oh, okay.
So even in patient with adenoma, we can do, if they refuse surgery or if surgery is hazardous for this patient, we can rely on medical treatment alone with follow-up of the case.
Right.
Dr. Dawlat, Dr. Ramadan Arafa wants to comment. And please,
Dr. Ramadan is a dear colleague. He is one of my colleagues in Mansoura University. We share our residence together.
Dr. Dawlat, I will unmute him.
Yes, please do.
أنا ليا شرف يا دكتورة غادة أن أنا كنت زميلك في اسم 3. Thank you so much for this very fruitful, very informative presentation. My point regarding the Riddle syndrome, because I have a patient highly suspected to be a Riddle syndrome. Do we diagnose only by presence of hypertension or refractory hypertension in the young age plus hypokalemia and metabolic alkalosis with low aldosterone level and low renin activity, or we should proceed for further investigations?
So at first, this is an autosomal dominant disorder, so you will have a family history. Secondly, you will rely on the presence of low aldosterone and low renin, together with manifestation of mineralocorticoid excess.
So, hypokalemia and metabolic alkalosis mainly.
Hypokalemia leads to metabolic alkalosis, yes, as I just mentioned. with early onset, and it is a family history of the presence of the syndrome together with hypokalemia. But in this case, we will have hypokalemia with low aldosterone.
And do you prefer
yeah.
to start combination therapy from the start, or to start first with aldosterone antagonist? If no response, then will you proceed for combination therapy?
So this is different if the patient is already hypertensive and on medication, or if the patient is naive. This means that he is the first time to receive antihypertensive, and he is diagnosed with primary aldosteronism. For primary aldosteronism, first you should use mineralocorticoid and increase the dose after 2 weeks till reaching the maximum tolerable dose, unless there is no contraindication and no side effect. On the other way, if the patient is on medication and he is not controlled, so you can add mineralocorticoid receptor agonist as an add-on treatment in this patient, because you hear me, Dr. Ramadan?
Yeah, definitely.
Sorry, I feel that the signal.
No, I'm listening. I'm listening. Yeah.
نعم.
سامعك.
Okay, so this is different. If we have a naive patient, we prefer to start with the mineralocorticoid receptor agonist, and if you have a patient with resistant hypertension, this can be added as add-on, even in studies away from primary aldosteronism. We can use mineralocorticoid antagonist as the fourth measure in treatment of hypertension.
Right. Dr. Saeed Khamis wants to comment as well.
شكرا جزيلا.
تفضل Dr. Saeed.
Thank you, Professor Dawlat. Thank you, Professor Yasser, and thank you, Professor Ghada, for this elegant presentation. Just I have 2 comments and 1 question, if you allow me. 1 comment regarding the primary hyperaldosteronism, or what's called Cone syndrome. That's for this, our junior colleague. The most common cause of hypokalemia and hypertension, and sometimes even contraction acidosis, it is due to the use of diuretics in a patient hypertension, which is more common for sure than essential hypertension.
Yeah.
So we should think firstly in this essential hypertension treated with diuretics causing hypokalemia. I mean potassium losing diuretics like furosemide or whatever. The other comment is regarding maybe you didn't mention this pheochromocytoma because lack of time. The pheochromocytoma, practically I faced this case once before. I mean this special case of pheochromocytoma, and the patient received metoclopramide outside my hospital at that moment. Metoclopramide or Belazil or Brimbran or whatever, it is absolutely contraindicated in a patient.
Yes.
It can lead to fatal.
Crisis.
It can lead to fatal shock, or what's called the nasty shock. So for our colleagues also try to avoid giving this metoclopramide for a patient with pheochromocytoma coming with severe hypertension and vomiting, and so avoid this metoclopramide. So it's very important. My question regarding the genetic screening for this genetically determined cases of Liddle syndrome or Gordon syndrome or whatever this genetically determined hypertensive patient. Is there in a place to do this genetic screening or no need to do? Thank you so much.
Thank you, Dr. Saeed, Professor Saeed. Actually, to add to your comment on the diuretic use, that hypokalemia is or a presence of hypokalemia in hypertensive patient is mostly or most commonly due to the use of potassium-losing diuretics. This is correct, and that's why before confirmation or before adding one of doing the assay for renin or aldosterone, we should correct the hypokalemia.
Yes.
Yes. So and stop all the potassium losing diuretics. For the genetic counseling, you open what is it? A scar. We need the genetic labs and the genetic counseling in many fields, not just in familial primary aldosteronism or other syndromes related to mineralocorticoid, but we need them in many familiar form of GN and so on. And Dr. Subh once in one of the meetings, he stressed on this point that we need to have a genetic lab and a place for genetic counseling in Mansoura or in other places, because this is lack for me in Mansoura. I don't know in Cairo or in other universities. We just do genetic counseling for restricted cases, maybe with in the pediatric department, and for research.
Yes.
Yeah, I never faced someone to do genetic typing for other diseases.
Yeah, right. You are. Thank you so much. Thank you.
Thank you. There's another question here. What is the percentage of hyperaldosteronism in dialysis patients? Is it like normal population?
So in CKD, in general, CKD is a cause of secondary hyperaldosteronism. So aldosterone is, and kidney failure or CKD is a state of aldosterone excess. So it is expected that aldosterone is high in patient with end-stage renal disease and those on dialysis.
As a cause or a consequence? I think this is the question.
Yes, it is both. Maybe it's a cause or a consequence of renal impairment.
Okay. Somebody here has a case. If a patient on more than 4 classes of antihypertensive drugs and still not controlled, calcium channel blockers, mineralocorticoid antagonists, ARBs, alpha blockers, beta blockers, and loop diuretics. Definitely this looks like secondary. No coarctation, no renal artery stenosis, elevated metanephrines or hypokalemia. كل ده normal. Serum aldosterone is high, but ratio of ARR is low. No lesion in CT adrenals. What is the next step?
So theoretically, or according to the guidelines, he should do adrenal vein sampling if he has a high aldosterone and high ratio ARR ratio. But we should search for clinical and laboratory evidence of secondary causes of hypertension, because this uncontrolled blood pressure may. You hear me?
Yes.
Yes.
I'm sorry, I have some flashes in the
Ahmed Mohi el-Din.
No problem.
He didn't mention chronic renal failure.
Yeah, yes. So renal failure is the first.
Yeah. No renal artery stenosis, elevated metanephrines, not elevated yani, or hypokalemia. Nothing of this is there.
Yeah, so
I think the only left thing is the renal vein sample.
Yeah, vein sampling. Yes.
For other causes of secondary hypertension, you should clinically examine the patient for evidence of Cushing, revise the drugs that the patient take, first revise his compliance and that he takes the medication, do a thorough clinical examination for evidence of any secondary endocrinal or non-endocrinal diseases, and continue the investigations. And if he have high aldosterone, as he mentioned, and high ARR ratio, he should do adrenal vein sampling, although it is just done in highly qualified centers.
Yes. Professor Sahir Al-Khashab wants to comment.
Please unmute yourself, Sahir.
Thank you, Dr. Yasser. Thank you, Dr. Dawlat. Thank you, Dr. Ghada, for this elegant lecture. I have two brief comments and a question. The first comment is that we internists, we have the impression that the Con syndrome is very rare, and then again, after the close connection with the urologist in the era of the transplantation, I found that they get lots of cases of Con syndrome or primary hyperaldosteronism. The patient discovers then that he is hypertensive. So we have the impression that it is of low incidence. No, it's of high incidence. And the problem is that they come to the surgeon and he excises the adrenal tumor. And the problem is, what I want to mention is that these patients continue to be hypertensive, maybe less hypertensive, but they continue to be hypertensive, and the lack of communication between us and the surgeons, whether the urologist or the general surgery surgeons, causes these patients to get lost. And then we see these patients years after with renal failure. So the problem with the genetic lab may be sophisticated, but our relationship with the surgeons may be an easy solution to these patients. The second comment is that these patients, I think, even after the excision, as I said, they continue to have hypertension, and after transplantation, when they get renal failure and reach end-stage renal hypertension, they continue to have a very high risk of cardiovascular syndrome. What I want to ask Dr. Ghada is whether did you have any the problem with the genetic lab, this problem, did you have any clinical or practical impact of the genetic test on any of your patients? Because I think this is the main problem, that the patient doesn't want to do these genetic labs, even if they are present. They are present, for example, in Asr but they are expensive and they don't really lead to a clinical impact. As you said, there is always a dilemma between diagnosis or treatment. So the patient wants the treatment. He doesn't want really the diagnosis. So did you have any case where the genetic tests did a clinical impact on the patient?
You mean in primary aldosteronism?
Yeah.
Yeah, no, I don't. We don't do genetic counseling. We don't have, unfortunately, we don't have this in Mansoura.
Okay.
Even in every place we meet this problem, even with FSGS and in many cases. I think it was done for sometimes in National Research Institute, but I don't know what's the state now. But it's very difficult to do genetic tests for any of our diseases.
Yes, it's just for researches, but not for patient diagnosis.
It's there in Abu Rish, in Cairo University, and in Asr. But the problem, Dr. Ghada and Dr. Yasser, that after we get these genetic tests, they're very confusing. And for example, in cases of FSGS, this is a many clinical cases I've seen. After you get the genetic test, you're confused. They don't lead you to anywhere. And this is, I think, not the problem of unavailability, but the problem that they really don't clinically impact, after all, the patient yet.
I think, of course, they have a clinical impact, but the problem is on our interpretation, how to use to interpret the test. And equivocal tests are present everywhere in every test. And
Yeah, I think that we are not familiar even with interpreting genetic.
Exactly.
Yeah.
You're not familiar.
Yeah, so
and,
you will be astonished, or when you read a genetic report